will take up the first subject anemia during pregnancy.
In these sessions, we will discuss further about the management component of the heart failure, and here I would like to hand over to Dr. Ramesh Arora to continue the topic.
Discussing further about the management of heart failure, we were just coming on to the device therapy, and we started with biventricular pacing or CRT. Now, how to select these patients is an important point, and in which we have to see whether there is atrioventricular dyschrony, intraventricular or interventricular dyschrony. Various echocardiography modes are used, and with the help of M mode, we can see that there is a septal to posterior wall delay. This delay should not be there, and if the delay is more than 130 milliseconds, then these patients are selected for the management. The idea of knowing all this is to have the better outcome with the CRT therapy, that is, the patients will respond better to the therapy. Now, these images are just showing us, these are 2D images which are in the 4-chamber long axis and in the 2-chamber view, 4-chamber, 2-chamber and long axis. Now, the color has been given to it. The idea is to avoid with the naked eye so that there is no mistake done in looking at it, and the color has been added to it to see. If you see now from the septum to the lateral wall, there is a delay and the color is different. In all the, you can see from here to this in the long axis, in the 2-chamber view as well, you can see. And what is being shown here is that right from the septum to the lateral wall or to the inferior wall or posterior wall, there is a delay which is more than 200 milliseconds. So what we needed for the CRT therapy was 130 milliseconds. Now, with the help of tissue Doppler imaging, which is there in most of the echocardiographic machines available now, from the septum to the lateral wall. Now, you have a Doppler here. You can see the colors also, that one is a septal and another is a lateral wall. The peaks should have been together. They should coincide with each other in a normal person. Here, from the septal to the lateral wall, there is a lot of delay. And this delay, more than 130 seconds, is telling us that this patient might do better with the CRT therapy. Then, this you have not seen in your own echocardiographic machines, and you will see that there are vector velocities. That is, when the ventricle contracts, all the walls are coming together. This is normal. But if you have a left bundle branch block, you see how the septum is going and how the lateral wall is going. They are all going in a dyschrony manner. So this synchronization is a feature, and this is what we have to recognize. Then this is from the right ventricle to the left ventricle, that is the time to the pulmonary flow or time to the aortic flow. This shows interventricular dyschrony, and if this difference is more than 40 milliseconds, then it is diagnostic. Now, there are speckle tracking images available, and these images, they show the radial strain. This is a short axis left ventricle, which you can see, and from the various segments of that ventricle, the Doppler velocities or the strain patterns are being taken. The radial strain, they are synchronized in the normal person, whereas in the lower field you can see that they are all dyschronized. The whole main idea is to recognize whether this patient has disc synchrony or not, because if they have proper disc synchrony, they are going to benefit, otherwise not. As such, with the help of CRT, 70% of the patients, they improve. Not everybody improves. Of rest of the 30%, some remain the same, others deteriorate as well. And why it happens is that most of the time, for the synchronization to occur, we do not know the left ventricular lead, wherever we have kept in the coronary sinus, whether it is really synchronizing with the right ventricle or not. So the whole idea of synchrony is to be maintained, and that's how we get it. Along with the CRT, we are getting number of other sensors and ICD as well. Some people believe that once you give CRT and synchrony occurs, then you need not give ICD, because most of these patients, the arrhythmia improves. Others, they do require ICD along with it. It comes as a single device. Then CRT with fluid sensors, which you can see here. The sensors are here. The point of what do you mean by the fluid sensor? There is an external device which communicates with the CRT sensors, and they measure the amount of fluid in the lungs. That is how the lungs are being shown here. And this means that you can optimize the dose of diuretics and reduce the hospital visit, as well as the patient's hospitalization is not required. Stem cell therapy, or the gene therapy, which we all talk of, and for all diseases this therapy is being talked of. So far investigational and is being given to some of the human beings, and this trial has been conducted at All India Institute of Medical Sciences in cardiomyopathy patients. How do we obtain the stem cells? They can be from the muscle cell, which can come and they will increase the myoblasts and they will increase the repair the injury. It can be obtained from the adipose tissue or from the embryonic cells. It's very well known in the literature about the embryonic cells, but these cells are only 5 days after fertilization and they are immunogenic, they are not used. Then comes the blood cells. These erythropoietin cells or hemopoietin cells, they only are used for the epithelial cells of the GIT tract and skin. Now we are left with umbilical cord cells, which is nowadays you have seen that there are banks available, and when the baby is born, then the umbilical cord cells are being stored and kept in the bank. Lastly, the bone marrow cells, which are being used and they are being tried in various diseases. What is a stem cell? Stem cell has a property which is clonogenic and newly remodeling, that is newly differentiating all the time, that is all the time their new cells are being formed. And what those cells are, either they remain as a stem cell alone, or they can become a specialized cell if they are implanted into the brain cell, if they are in the muscle cell, if they are in the blood, RBCs, if they are in the heart, then myocytes. And these myocytes, once the stem cell converts into a myocyte, they integrate themselves into the wall and increase the contractility. Thus the synchrony is maintained and they avoid the electrical deactivation or dyssynchrony, so that to avoid congestive heart failure. How these cells are given? They are given intracoronary, that is when these patients, supposing there is a patient of acute MI and is undergoing PCI, then intracoronary infusion with the specialized balloons, the delivery can be given. Then catheter-based intramyocardial needles. Some of you must have seen that there are machines available in your for RF ablation, where these are called NOGA or 3-dimensional color coding machines, and with that help we can make out the scar tissue and the normal tissue, and we can find out where the scar and the normal tissue is, knowing that with the help of the percutaneous needle we can inject at the site where the demarcation of the normal and the scar tissue is, because that is the site where we are going to have more of cardiomyocytes developing from the bone marrow cells which we are going to inject. And lastly, during surgery we can inject these cells onto the site and obtain the results. A large number of trials are going on, and they are there, and it has been seen with the help of bone marrow mesenchymal cells in the BOOST trial, which was given intracoronary at the time when primary PTCA was done, and it improved the ejection fraction as compared to the placebo. It was 6.7% versus 0.7%, but there was no change in the risk of restenosis. We are not expecting that. Actually, we are only expecting the improved in the ejection fraction. It can be given passive, intravenous, or they can be given MAGIC trial. It has again been given intracoronary, but they have been the peripheral cells. Then in POSMAN trial, they have been given intramyocardial with the help of that NOGA machine I was telling you, which is used in RF ablation and percutaneously at the site of demarcation. And top care again intracoronary. All these have just shown improvement in the ejection fraction, no change in restenosis, or in fact one of the trial has shown more restenosis in these patients. The question is that how to take these bone marrow cells. We don't know when the patient is going to have myocardial infarction and whether his bone marrow should be preserved. So all these things are being now talked of and now being thought that just like umbilical cells are being stored, can the patients who have a greater risk of developing coronary artery disease give their bone marrow cells, and they will be preserved and used at the time when it is really required. These are just questions in mind and ideas which are being speculated. Coming on to the other devices which are called assist devices. They are not percutaneous, they are surgically implanted assist devices. We know that the patients have been given cardiac transplantation, and many of the patients who have received transplant, they need immunosuppression drugs. Donors are difficult to obtain. In the last few years, we have seen that the number of cardiac transplants have reduced tremendously as compared to when it was started, and there was a lot of enthusiasm about it. Moreover, the criteria has been revised, and it has been said that those patients who are less than 65 years and those who really do not have any comorbid conditions, they benefit better, so they are the ones who should be selected. Because of this, number of patients are left behind and do not fall into these criteria, so something has to be done to these patients. Then artificial heart is being tried, and then a large number of left ventricular assist devices are being there. Here you can see that there is a device. You can see this cannula, that the blood is sucked from the left ventricle, it is put into aorta. The whole idea is to reduce the function of the heart. We want the heart to rest, and we want the heart to heal by the time we remove these devices. Supposing if there is a patient of myocarditis in gross failure not improving, the device is given. Once the inflammation resolves and the patient recovers, the device can be removed. Sometimes following coronary bypass surgery, patients are in failure and they are given assist devices for a certain period of time. The belt is there and the triggers are there, and you can see that how they are. This device which I have shown you here is called a left ventricular assist device. It can be a ZAR. There are a number of ones which are available. The last one which I will tell you is a Novacar, and that Novacar fits into the abdominal wall, and the circulation is the same as it is shown here, and around the belt is a battery. The battery can last for about 10 to 12 years. The battery is rechargeable and replaceable, so that the many patients who cannot be benefited by other means, they can be benefited by this and they can lead the normal life. The devices are expensive, and many of them, many people cannot afford them. Lastly, the surgical ventricular remodeling. Now, as I told you that the transplantation is reducing because of certain points. So, and the many patients who are left, can they be benefited by surgical means? Yes. Sometimes when we do coronary artery bypass surgery, then there is a ventricular aneurysm, and that ventricular aneurysm is resected. Then at the same time, the idea is to remove the thin scar tissue. If we remove the skin scar tissue, the thinned out myocardium, which is not of any use for energy, then we reduce the size of the left ventricle, we change the shape of the left ventricle, and that improves the ventricular function. So if you see right down here, right lower corner, is a door procedure. This is a procedure in which the apical, apicolateral and the epicoseptal tissue is removed from the apex, and then the linear stitches are put, or if the sutures are too long, then a patch is to be used. Similarly, when it is at the anterolateral wall, a linear stitch is given, and if it is at the septum, septoplasty is done. The whole main idea is just the same. Lastly, patients have dilated cardiomyopathy when the wall is thin and the ventricle is dilated. In them, it is like a double breast jacket. That is, the thin area is, if you can see here, is a breast-like modeling. The cavity has been reduced, the walls are good, thickness is better, and the contractility has improved because of the geometry as well. So these are the various methods just to assist. Now, apart from giving the devices which are implanted, can we have the external constraints also? That is, on the surface of the heart there is a polyester mesh. This mesh system is called a cone cardiac support. It reduces the wall stress. Once it reduces the wall stress, it doesn't allow the ventricle to dilate, and the volume is becoming less and the ejection fraction is increasing. The stress is becoming less and less to the patient. Similarly, there is another system called myocar myosplint system. There are tension bands which are through the right ventricle, or it can be through the left ventricle, and these tension bands, they reduce the size and improve the myocardial contractility. Now, apart from this, there are various percutaneous techniques which are coming up, because many of these patients are so sick that they cannot be taken for any surgical procedure. Anesthetists are most of the time scared and they cannot give anesthesia. They call them a very high-risk patients because of other comorbid conditions like kidney failure or COPD in these cases. The mechanism of heart failure, which can be from the various reasons as we have known now, so that can cause mitral valve dilatation, or is only a LV dilatation with the asynchrony, or the geometry is lost, so the patient develops mitral regurgitation. These are not the patients who had a rheumatic heart disease. They are just ventricular dilatation patients. What can we do for them? Percutaneous options for mitral repair are now available. What surgeons have been doing is that they have been doing edge-to-edge repair. This edge-to-edge repair has shown good long-term surgical results. Based on that idea, the various devices and stitches have come up percutaneously to reduce or to repair the mitral valve. Then the devices are being put into the coronary sinus, because coronary sinus is very close to the posterior mitral annulus. So it compresses and reduces mitral regurgitation. The ways of this is very interesting, that the radio frequency is being used at the sides of the mitral valve so that the fibrosis occurs and MR regresses. Similarly, since one device has come, the number of various devices with the same type of function, they are coming up now. I'll show you the ones which are being used at the moment. This is just to show you that edge-to-edge repair with the help of a grasper and sinuplasty, that is putting a compressing device in the coronary sinus to approximate the posterior mitral annulus, is being used to reduce MR. Clinical trials are there, and even the centers who are approved, it is being done on a routine basis in most of them. And if you can see here, This is like a grasper which we use for drying our clothes most of the time, and exactly the same shape, and we have to put it percutaneously. If I can show you that this is our inferior vena cava, come from the vein, go to the intrathecal septum like a mitral valvoplasty, and come to the valve and deploy the grasper and come out releasing with the remote phenomenon. This is what we have done, and this is the real E valve which is being deployed in the patient, and now you can see that the regurgitation has reduced in size. Not only the valve, just like the surgeons put the stitch on the catheter is there, and this stitch is trying to just approximate the edges. You can see the thread coming out of the catheter like a needle as we use, and it is trying to stitch and approximate the edges of the mitral valve in order to reduce the size. This is a coronary sinus approach, and here is a coronary angiogram. We can just see all this and the coronary sinus. I'll show you how this device comes. The device has a proximal and a distal anchor, and in between the body of the device, and this is placed in the coronary sinus. You can see the echocardiogram before and after the device. This is MR before and MR afterwards. Now, there are now certain patients who are in failure because of aortic stenosis. They are at the age of 65, 75, 70, along with other comorbid situations, and they cannot undergo aortic valve replacement by surgery most of the time, and they are rejected by the surgeons. A lot of experiments have been done. 50 years we have taken to come out to a valve which we can do in a human being, and this human implant is in a 57-year-old patient, was done in 2002, and following that this is being done routinely in many patients. And if you can see that this is a prosthetic valve which is there in an open condition. It is a crimped one, and this one also can be deployed from the vein IVC coming on to RA, then to interatrial septal puncture, coming to LV, and then going to the aorta. Or we can come retrogradely as we do aortic valvoplasty. So this is a valve which is sutured with side, and it is within a stent. This is about 500 cases have been done so far, and the results are quite satisfactory. But still we do not have a proper valve in the sizes, because aortic regurgitation has occurred in number of these cases as well. This is just to show you that the valve has been deployed. There is no aortic regurgitation, and the aortic stenosis is not there. You can see in the TE also how the leaflets of the valve can be seen in systole and diastole. Now, percutaneous deployment of the aortic valve not only is of one type, one comes, the second one comes. Because once you have a stent, then you cannot increase that size. And aorta, in aortic stenosis, you all know that it has a post-stenotic dilatation. So it is not a linear thing. It is not of the same size at all the places, this place, this place. So we must have a self-expandable thing so that that can take the shape of the aorta. This is just showing the dilatation of the aortic valve percutaneously from the retrograde method. The earlier valve which I showed you was going from the interatrial septum from the venous side. This is from the femoral artery that we are coming and ascending aorta, crossing the valve and into the left ventricle, and the balloon is here doing aortic valvoplasty, and then following that the valve in the crimped position is here, and the valve after opening, the mesh is just an expandable stent within which there is a Edward type of a valve which has been stitched. This is one of our own cases which we have done in Metro Hospital about 2 years ago, was the first case in India. Now, once we are given all these therapies, what happened to these patients? The mortality with the various devices and the long-term follow-up really is not altered most of the time. But what is altered is the symptomatic improvement. if we give the CRT therapy or biventricular therapy, it's not that we are prolonging the life of an individual. What we are doing is that the symptomatic things are improved. Once it has been done, then how do we monitor these patients? There are monitors available, and that the patients do not have to come to the hospital all the time, and these are also implantable monitors. The one which is shown here on the left hand corner, and this is called Chronicle. This is a monitor which is implanted in the body, and we have a remote control in our own hand, as well as there is a monitor. The patient continuously monitors, and once a week the data from the house is sent to the center, and once the data goes to the center, the data is analyzed by the physician, and they try to adjust the dosages. About 275 patients have been done, and they are enrolled in this trial which is called COMPASS trial. The most important in this is to measure the intracardiac pressure. That is, what you want to know is the left ventricular and diastolic pressure or the LV pressure, because you want to adjust the dosages of the various drugs depending upon that. It's not very easy to monitor that data, but this is what is being tried to do, and the hospitalization of the patient is being reduced. The other type of a sensor which I have shown you here on the right hand corner, and that is called heart pod. This is really very interesting, and that is, there are two components. There is a one component which is stitched to the atrial wall in the body, and the other one is a module plus a monitor. And this module and a monitor, this is in your own hand with the patient and what it does is that it senses all the intracardiac pressure, and this word POD means physiologically optimized dosimeter. Before the patient develops symptoms, there is a change in the intracardiac pressures. So what it is measuring is the intracardiac pressures hours or even days before the patient develops symptoms. So you are trying to alter the drug and the treatment before the patient develops the symptoms. So this is a physiologically optimized dosimeter. It is measuring the pressures inside and is trying to adjust the dose of the drug. So this is the most useful monitor which is there. But mind you, these are all, they look all theoretical at the moment, but once you have a number of patients and you have all these things readily available, it will be much better for the patient not to be coming to the hospital and the dose being adjusted with the help of these dosimeters, and the patients will be feeling better and not becoming symptomatic with failure every time and every time reporting to the doctor and the doctor trying to adjust the dose. So this is what is available now with us. These are the things which I had to tell you. There are a number of other modalities which are there and number of other things which are there. Supposing the patient has mitral regurgitation, we have to do MVR. If the patient has aortic regurgitation, we have to do AVR, coronary artery bypass surgery. All these things are in addition to what we have been talking, because we were not talking about each and every disease in detail. We were talking in summary about the heart failure. So leaving those things and leaving those into consideration, that those diseases are being treated by all of us, and then we are left with no choice. And when a no choice is left and the end stage occurs, then how do we approach these patients? And these are some of the newer devices, surgical modalities, and handheld monitors which are there with the patient implanted, available to us for better treatment and outcome. In spite of all what we have as the newer therapeutic agents, as well as we have the newer device management, most of these patients, they succumb to heart failure, and nearly 1 million people die every year of heart failure, whether it's primary or secondary due to any cause. Thank you.
Yeah, ma'am. Before ending, there are a few queries like regarding in your presentation and discussion. You mentioned about the fluid management, and you also mentioned that after certain period, this the diuretic become resistant and all this. Ma'am, actually, can you explain it in
Yeah.
a better way that how
Yeah.
this diuretics and fluid management it become resistance, and how much it is?
The point is, supposing a patient is taking one tablet of furosemide a day, the whole dose effect is over by the time the evening occurs, and that effect is over, and slowly it becomes a rebound. So one effect is that. The other is when when you give more of the dose, you increase the dose. When the diuresis is more, then the fluid balance in the body is less. Once the fluid is less, the splanchnic blood flow is reduced, the flow to the kidneys is reduced, and cardiac output is reduced. When the cardiac output is reduced, then the adrenergic mechanism comes into play, and this adrenergic mechanism, along with the less flow to the kidney, that is glomerular filtration rate is less, the renin increases. At the same time, this adrenergic drive, that is the adrenaline or noradrenaline, they act on the beta 1 receptors of the juxtaglomerular apparatus. It's not only the low glomerular filtration rate or low output, it is also the adrenaline which acts on the beta receptors of juxtaglomerular apparatus and increases the dose of renin. Once renin is increased, the angiotensin 2 is increased. Angiotensin 2 is again a vasoconstrictor, and it increases aldosterone, and all that increases the reabsorption of sodium and water, and the retention keeps on occurring. So the optimized dose has to be there. The third thing is, when we keep on giving diuretics or any dose, then our loop medullary system hypertrophy occurs. And what they do is that when the hypertrophy occurs in the early stages, always there is increased reabsorption of sodium and water, and that is what is causing you the diuretic resistance.
Yeah. And ma'am, regarding that acute and chronic heart failure also, is like any prognostic means difference between the acute or chronic, or it's depend upon this its means original cause or other comorbid state?
You see, when does acute heart failure occur? Acute heart failure occurs after acute myocardial infarction, or patients of acute myocardial infarction when they develop mitral regurgitation or ventricular septal defect. There is a difference between the two. Heart failure is occurring in both the cases, but the point is that if it is a ventricular septal defect, then the heart failure which is occurring, the natural course of that is that 80% patients die by 1 month. Whereas if it is a mitral regurgitation and the papillary muscle ruptures, then 80% patients die within 7 days. So it will all depend upon the basic disease and to which the insult has been added. Firstly, how big was the MI? Secondly, how big is the ventricular septal defect, and the mitral regurgitation. Mitral regurgitation is more ominous than the ventricular septal defect. So the drugs which we use, I told you, are mainly the nitroglycerin is being used, or sodium nitroprusides, they are being used as vasodilators.
Yeah. In case of management, ma'am, is there anything like a turning point from where we can shift to the like medical therapy to some device therapy or some surgical therapy or some kind of things? Is it like that, ma'am?
Yeah. When I was talking to you about the point is, when the patient is on optimum medical therapy and you feel that you have given enough, and the patient is coming to the hospital again and again, and patient is developing diuretic resistance as well, in those cases then you have to shift on to them to the device management. The device management, one is, I told you that synchrony and dyschrony is to be maintained by the help of CRT or cardiac resynchronization therapy. Then patients of arrhythmia to be treated by the cardioverters, and even the sensors have been added to detect fluid. There are patients still left, and many of them who do not have a left bundle branch block or not a candidate for CRT, then they are left for the ventricular assist devices. And when it should be given, there are indications for that, and they are when the blood pressure is less than 80, when the left ventricular end diastolic pressure measure is 20 or more, which is mainly the left atrial pressure, or whenever there is systolic, I told you systolic blood pressure less than 80, and diastolic pressure is more, cardiac output is less than 1.8 liters per meter square, and the urine output is less than 20 ml per hour. So they become the indications for going on to more and more assist devices, because these assist devices work in the way the left ventricle works.
Yeah, is it, ma'am, like some kind of things like, as you described that diuretics has got its own resistance and these things. Many times we found that only fluid giving the patient is also get a relief.
They are a different group of patients. Supposing we have an anterior MI and the left ventricular ejection fraction is low, in those cases they have patients are in failure, and these are the patients with the low pressure. They require diuretics as well as the vasodilator therapy. But if a patient has inferior wall MI, there you need a filling pressure which is required to be more. For that patient you need to give more of fluids. So it will all depend upon the basic disease which we are dealing with.
Is that, ma'am, there is like the causes of heart failure, most of the time it is because of heart itself, and most of the time it is maybe because kidney disease or some liver disease or maybe some anemia or some other neurological. So, ma'am, is there any percentage like it is only because of primary reason of heart or some kind of things or some
See,
other?
those diseases are different. They are mainly non-cardiogenic. They are grouped under the heading of circulatory failure. They are hemorrhagic shocks and septic shocks. They most of the time maybe in the septic shocks also at times because of the interleukins being found or the cytokines being there the ejection fraction becomes low, and once that infection is over, then the ejection fraction is more. Many times people say so and so found a low ejection fraction and so found a high ejection fraction. This may be because of the improvement or deterioration in that patient that the change of ejection fraction occurs. It does occur, but most of the cases are cardiac cases, and they are primary heart patients rather than patients coming to us from the respiratory units or from the nephrology units.
So here we would like to stop the sessions, and I would like to thanks to Dr. Ramesh Arora because she spent her valuable time and described you regarding this heart failure. Thank you very much.